Hi everybody, it's Melissa from Aim at Melanoma. I'm coming to you live again here on Facebook to talk about BRAF and everything BRAF. Now, a lot of these things are also found on our website. You can also look at the Melanoma Nursing Initiative, release some videos that kind of talk about all the things that I'm going to try to address tonight. You can also see these videos on our website as well. So I'm going to try to go through BRAF as simply as I can make it. I know when we talk about genes, things get a little bit scary. It sometimes seems really confusing. So I'm going to try very hard to make it as simple as possible. If you have questions while we're going along here, please leave them in the comments. I'll try to address them as we go along so we don't lose anyone. If after the fact you think of questions, you can email me through the website. You can call my toll-free number. You can leave a comment. We'll try to get all your questions answered because we want to make sure that everyone is educated. So basically, we're going to try best we can to make this as easy, as painless as possible. So let's talk first about what is BRAF. BRAF is actually a gene that helps control the way your cells grow. So it's a gene that then tells a protein that then tells your cell how to grow. It's like part of the instructions of cell growth. So when you have a mutation in this gene, essentially what that means is that it's different from normal. So that means that the instructions that your cell is getting are not normal. They're different. So it'd be like trying to read instructions from IKEA in Spanish. Like if you don't speak Spanish, it's definitely confusing. So, but what basically happens is that mutations in the BRAF gene tell the cell to grow more aggressively. So you may find that these melanomas sometimes spread a little more easily to the lymph nodes that drain them. They may recur a little bit more frequently. And so there's a lot of data out there that says, you know, having the mutation in BRAF is a poor prognostic sign. That's not exactly true. We'll talk about it a little bit later. It does mean that your melanoma will be a little more aggressive, but also now there are agents both in stage 3 and stage 4 that can actually block this mutation from being expressed in the cells. So that's important to know. So what essentially happens is about 50% of melanomas harbor this mutation. And the most common mutation is V600E, which basically just means that the gene at the 600 location on your cell is mutated and different. Most of the time, these mutations are seen in cutaneous or skin melanomas. And that's where like the around 50% of the time, BRAF is mutated in skin melanomas. You have different types of melanomas in things like mucosal and ocular that we're not going to really talk about today. That doesn't mean they're not important. It just means that, you know, most of the time you do not see BRAF mutations in ocular and mucosal origin melanomas. If you do have the mutation of BRAF, what it means is that the way that you'll see that reported on a pathology report is you're BRAF positive or you're BRAF mutated. If you do not have the BRAF mutation on your tumor, you'll be known as BRAF wild type or BRAF negative. A lot of times the way it's reported is mutated or wild type, so that's entirely what it means. And actually next month when we go through how to interpret a pathology report, we'll talk about that as well at that time. So that's basically in a nutshell what BRAF is. Hello, Kay and Kelly, how are you? Okay, so the next thing that kind of comes up a lot is the BRAF gene inherited? And I don't, because when you talk about genes, immediately you think like, oh my gosh, I'm going to pass this on to my kids, or did I get this from one of my parents, or do I need to get other people in my family tested for this? The answer is no. The BRAF gene is, hi Ed, the BRAF gene is not inherited. It's actually an acquired mutation. So in genetic terms, this is also called a somatic mutation. But if you're not taking biology, that doesn't matter. What you need to know is it's acquired. It's not inherited. It's not passed on to your children. It usually occurs spontaneously at the cellular level, which means that it's not programmed into your cells. So things like sun damage, severe burns, those types of things tend to create an environment where DNA damage occurs, and then spontaneously the BRAF mutation happens. The flip side to that is actually germline or genetic mutations that are programmed into your cells. And those are like genes that are made in sperm and egg. There's nothing you can do to alter them. That's why you have brown hair or light skin, freckles, etc., etc. So very, very different. Not like BRCA. So it can be present in other tumor types. Like sometimes you see the BRAF mutation in lung, colorectal, thyroid, head and neck. It doesn't mean that if you have the BRAF mutation that you actually have to get tested for those other malignancies. That's not how it works. It's just that there are mutations of BRAF also found in those types of cancers. It doesn't mean that you're more at risk to develop those. So just want to make sure everyone knows that so that you don't worry. Let's see what else. You don't need to get screened for other malignancies. That's one important thing. Hi, Pauline and Margie and Deanna. How are you? Miranda, let me read your question. It says, I have melanoma on my left lower leg. Nodular said it's nodular. Could I have BRAF if all of my grandparents on both sides have melanoma? So again, that goes back to the BRAF isn't inherited. If you have a melanoma, that has a significant depth, you definitely should ask your dermatologist, ask your PCP, ask your oncologist to run it for BRAF. That's helpful information. A lot of times they'll only cover insurance wise for patients that are stage 3 and 4 to have BRAF testing done. We'll also talk about that a little bit later. But definitely, if you have stage 3 or 4 melanoma, you should for sure, Miranda, get your BRAF checked. And you can just ask your doctor to do that. We'll talk about that in a minute. Okay, so the next thing that I want to kind of try to address on here are myths, because, we don't want everybody knowing unfactual information. So one of the big myths that is out there is that BRAF only occurs in young people. It does occur more commonly in younger individuals, and they did notice that this is a trend that has been observed, but that doesn't mean that it doesn't happen in older people. I can tell you, in my clinical experience, there are hundreds and hundreds of patients that are above age 50 that have the BRAF mutation. So while they see this a lot in younger patients, it can be present in older individuals, so you should still get screened. Both young and old should have BRAF testing if it's indicated for your stage of disease. The next myth that comes up a lot is if I'm BRAF positive, that definitely means my cancer is going to come back. Now, remember in the beginning of the talk, I did say that, certainly BRAF tumors tend to be a little more aggressive. They tend to recur a little more frequently from the data that they looked at retrospectively. Now, that doesn't necessarily mean that because you're BRAF positive, your tumor is going to recur. There are plenty of people that are BRAF negative that tumors recur, and also people that are BRAF positive that your tumor never returns. There are a lot of different things that influence the risk of recurrence, and those things are like the Breslow depth, which is how deep the tumor actually goes into the skin, whether or not your tumor was ulcerated, if there were a lot of mitoses, which is how actively they divide. If it already spread to the lymph nodes, or if you've already had a recurrence, those also contribute to the overall risk. So BRAF being positive or negative is only one piece of the entire puzzle. So it does not mean, for sure that your melanoma is going to come back if you have the BRAF mutation. On the flip side, there's I'm BRAF negative, I don't need to worry about it, I'm all good, everything's fine, I'm BRAF negative. Again, for the same reasons as I just talked about, that's not true. So just remember that there are a lot of factors that go into risk of recurrence, not just the BRAF. So that's not, the end all be all of prediction for prognosis at all. So just keep that in mind, both as positive and as negative. Another myth that comes up a lot is that the BRAF status will tell you how you got your melanoma so you don't get another one. It's not a predictor of, will I get another melanoma down the road somewhere. It doesn't tell you anything really about why you got melanoma. I think that the basis for this myth is saying that like they see BRAF mutation more on sun-exposed skin. And it actually doesn't occur more often on chronically sun-exposed skin, according to some studies. It definitely will not tell you whether or not you're going to get another melanoma. It primarily is for treatment options, truly. So you still need to practice sun safety. You still need to have regular follow-up to, get your skin checked. I'll get on my soapbox all the time. Please get skin exams. And be very careful in the sun, because those are the two best ways to prevent new melanomas from coming back, and also to catch a recurrence early. Those are all really important things. So BRAF status, some of the myths, trying to bust them up. So hopefully that helps people. I'm going to turn my page because I have some notes so I stay on track today. This is a big topic and we don't want to miss anything. Okay, so again, earlier in the talk, I talked about like who should be tested. It's recommended that anybody that has a stage 3 or stage 4 melanoma be screened for BRAF. This is very important in making decisions in terms of treatment options. Also some stage 2 patients. If you have a really deep melanoma, that is, greater than 4 millimeters in depth, in Breslow depth, it would probably be a good idea to get tested as well. I know a lot of people worry about reimbursement. A lot of stage 2 patients now can get tested in the context of a clinical trial, because there are many now clinical trials that are being run in an adjuvant setting. So definitely stage 3, definitely stage 4, and in some appropriate cases, stage 2, if it's part of a clinical trial. So, really, and if you don't know, ask your doctor. Your doctor will tell you whether it's appropriate, but definitely stage 3 and 4. How's this test performed? There are various testing methods that are used. There's an immunohistochemistry test. There's companion tests. You'll get very bogged down worrying about those things. Don't worry about those. At the end of the day, you need tissue to test for BRAF. So, you need tumor tissue. Your oncologist, your dermatologist, your surgeon, whoever that is that obtains this tissue will actually ask the pathologist to run this test. A lot of times it's run in a combination of BRAF, NRAS, NF1. I know we do at our institution. Those are all genetic alterations that are seen sometimes in melanomas. But that's something that may not be routinely run on your tumor at your institution. So it's something that may need to be requested specifically. So your oncologist, surgeon, whoever your physician is, will need to ask that to be run. It's actually a DNA test where they extract the DNA, they run it, they cure it. It takes 7 to 10 days sometimes to get results back. So, and sometimes longer if the pathology has to be obtained from somewhere, or if there's not enough tissue in the original biopsy, they may need to get a fresh biopsy of an additional tumor. Your doctor will decide that for you. So, once it's determined that you need BRAF testing, they certainly will look for that. Will this get paid for? We definitely see a lot of patients that are so worried about reimbursement, so much so that some patients are like, oh, don't run BRAF on my tumor because that's an expensive test. I don't want that to get run. It's actually reimbursed in stage 3 and 4. There are also some grants and things that are available and nationwide programs that will actually help you get BRAF testing if for some reason that isn't the case. You may have a copay based upon your insurance if you have private insurance. So that's something that may happen, but there are definitely programs out there that can help you if you can't afford to get BRAF testing. Again, if it's a clinical trial that is stage 2, for stage 2 patients, a lot of times the clinical trial will actually cover the cost of the BRAF testing as well. So, don't let the reimbursement picture prevent you from asking what your BRAF status is and having that tested. Cheryl, how long after melanoma diagnosis can this be done? Once they actually diagnose, like there's a pathology report that says you have melanoma, all they need to do is know what there's something on the pathology report called an accession number that actually is like a barcode for your pathology department to know which specimen is yours. And they can actually run that at any point in time. A lot of pathology departments, so it says the rest of the question is if you're years out but meet the criteria, is it prudent to do so? The answer is yes, for sure. And they can actually run it on old tissue. They do need unstained slides to be able to do the test. But a lot of times what happens when they diagnose your melanoma is, or it goes to pathology, is that they cut slides from a block and it literally looks like a little block of tissue. So they don't use it all. They save it in the pathology archives for things like this, like if they ever need to go back and test the tissue again. So, different facilities keep that tissue for different lengths of time. So that would be the only question mark in your case, but certainly, if it's a few years ago, there's no reason that they can't still run it as long as there is still tissue left in the block that they have that is melanoma. Amanda, if your BRAF test came back no mutation, does that mean it's genetic? A little bit ago, I actually talked about the difference between an acquired mutation, which is what BRAF is, and a genetic mutation. BRAF is definitely not genetic. So you can go back and look at it once I post it, and it may explain it a little better for you. But if you don't have the mutation, it just means that you don't, that your BRAF cells that tell your cells how to grow is normal. Cheryl, how expensive is the test out of pocket? I actually don't know the answer to that in down to the dollar, but it's several $100s for sure. And you're welcome. So hopefully everyone, and if you have trouble getting reimbursement, ask your doctor or call me. We'll try to help you. So all of these things happen. You got your tumor tested. You know you're BRAF positive. What the heck do you do with that information? What does that mean? So, hi, Barbara Addison. So what does that mean? Basically what it means is that you have the opportunity to do something called targeted therapy. So it's a treatment that will actually block the expression of this gene. So it's going to target the specific pathway that allows this to grow. A lot of times the doctor that I work for said it's like throwing a wrench in your transmission. So it seizes up your forward motion. A lot of times BRAF is given along with something called a MEK inhibitor because they're on the same growth pathway. It's like ERK, MEK, BRAF. And so blocking it in 2 spots in the pathway is much more effective than blocking it just at 1 spot in the pathway. And without trying to get too technical in terms of the pathophysiology of how your cell grows, you're essentially like cutting the legs off the tumor growth. What they see, or what we have seen in clinical trials in the past for getting these drugs approved, is that there are less side effects that are severe, like less severe side effects, and also a longer, more impressive benefit from using BRAF and MEK together versus using them just one or the other. Now, if you're BRAF positive, that doesn't mean that you have to do oral targeted therapy. You can also do immunotherapy. Immunotherapy also works very well. What is important is that you know that this is part of the option. BRAF inhibitors work very well for people that have the BRAF mutation. They don't work for people that don't have the mutation. So you definitely don't want to take these drugs if your BRAF mutation is wild type or negative. At the end of the day, the decision to take a BRAF inhibitor is between yourself and your oncologist. What makes the best sense for you based upon your tumor burden, like how much disease you have, you know, what form of treatment you want. Like, you know, BRAF inhibitors are oral. You take them at home. You have follow-up, but you take them at home every day, and then go into the hospital, or I'm sorry, to your physician's office for monitoring, whereas immunotherapy is given IV. So, you know, there's everybody has their own idea of what's most ideal for them. You know, some people are afraid to take oral pills because of the responsibility that they have to remember to take that and stuff. So, you know, just because you're BRAF positive does not necessarily mean you have to take these pills. It is a great option. It's an additional treatment option. People tolerate these medicines very well. Now, there are side effects to them. However, you can manage those side effects. Things, you know, they can be managed. Your physician will work with you to help. You know, if there's still issues, you can call me. I will help. But at the end of the day, the treatment decision should be a collaborative decision for you. Pamela, can you do this with in situ? BRAF is not indicated in situ. It's not indicated to test for that. In situ melanomas tend to not recur once they're properly excised. So there would be not a reason to need them or know the test in that instance. Cindy, my husband was BRAF positive. Just put on BRAF pills. I'm sorry, I'm trying to read this really fast. Honestly, Cindy, I would be happy to answer your questions off the air. On our website, you can either fill out a form and it'll get sent to me, or you can call my toll-free number. All of that is actually on our Aim at Melanoma website on how to get in touch with me. But I'd be happy to answer whatever questions that you have in terms of, you know, education things. I can't give prognosis or opinions about the way that things went, but I certainly would help. So, you know, please contact me. So I hope that clears up a little bit about BRAF testing and what BRAF is and how it's done. I definitely didn't want to get too much into the side effects. There are, I will say that there are various combinations of BRAF MEK that are available right now, 3 to be exact. They all have a little bit different side effects. They're all oral. The side effect profiles of each of them, each couplet, are a little bit different. It's something that, again, choosing which drug you get is based a little bit upon you. Like, I know at our institution, like, we kind of look at, like, okay, what kind of things do you already have going on, and we kind of pick the couplet of drugs to go with what we think you're going to tolerate best. So, you know, sometimes 2 patients will go into the office at the same time, be prescribed BRAF MEK, and not get the same one. So, you know, there's no real data to say this one's better than that one, or vice versa. So it's something that, again, you know, you can discuss with your oncologist, but just know that there are multiple options out there. I know that I really appreciate that everybody tuned in. I'm happy to answer any additional questions that anyone has offline. It's good to see a lot of my friends on here. It's good to see everybody. Thanks for listening. I will definitely be back next month, and we'll be talking about pathology reports and how to interpret them and what that all the stuff means, because there's lots of medical terminology that a lot of times doesn't make any sense. So we're going to go through like a mock pathology report that I'm going to make up. So we'll see you next time. Bye, guys.